All right. Thank you so much. Thank you. I was definitely excited about coming because not only do I obviously enjoy colorectal surgery, which we'll get to that later. It's kind of a mystery to you. But, just the talking about the cancer side of it. The reason it's near and dear to me is because these scientific truths, all this stuff about DNA and all this kind of information that goes along with cancer, I really held very tightly to, and was a big reason I was an atheist. I used that as, it was my kind of, stronghold and my truth. Then I was 19 years old in undergrad in pre-med, and a holy God in heaven just decided that I needed to wake up to the truth of things. So basically, what is cancer? So cancer is just a fancy way to say the dysregulation or abnormal proliferation of cells. The reason it's so common is because we have billions upon billions of cells every single day that kind of leave our bodies through just breathing out or fall off of our skin or go through other kind of excrement ways. So that's why it's so common. So billions of times a day we have this dividing of cells and DNA changing and all. And all it takes is a cancer is just an abnormal little DNA area to proliferate and that cell not get taken out and then it multiplies. So that's why it's so common. So basically, I do think that it is biblically accurate, because I have no reason to think otherwise. When a holy God in heaven made mankind, that He said it was good, apart from our ability to make some decisions apart from His will. That I think the body was not a perfect machine, but about as perfect as it could be. Then I think when sin entered the world, that it caused that sin and decay to happen, where those cells were no longer, at that initial created state, and then cancer things could happen. So basically that's the long and short of exactly what kind of cancer is, which we'll get into it a little bit here. I have no financial disclosures to anything I'll discuss, any surgery or any topic or anything like that. So colorectal cancer, it's one of the leading causes of cancer death, actually number 3 behind lung and prostate. But on the flip side, it is one of the most identifiable forms of cancer. Just like breast cancer in females, it is largely preventable because of screening, namely colonoscopy. As far as why it happens, well, I think one reason it happens is we just talked about just the fall of mankind, actually. It's just like all decay and all things not being perfect like God created them. That's one of the main reasons, I think. But second to that is genetics. Some of us are more genetically inclined than others to get it by family history. Dietary has some issues with it, red meats and things like that, but it's hard to hang your hat on that to say that's the leading cause. I don't think that's the leading issue for it. So, because my diet's terrible, and I eat kind of what I want to eat, and we'll just see what happens, I guess, in the future. But as far as lifestyle, just like most issues, they say a more sedentary lifestyle is more likely to lead to cancer. I think that's probably some other factors, not necessarily just a lack of exercise, probably other things that surround that. And then smoking has a mild increased risk as well. But I'd say by far the most common patient that gets a colon or rectal cancer is not something they did or didn't do. It's just going to happen to a certain amount of people. Like I said, it is largely preventable because of colonoscopy, and actually in the last 10 years, there's been almost a third, almost about 30 to 33% of patients have not developed cancer that would have in the colon or rectum because of colonoscopy. So because it's been more increasingly done by primary care physicians, like sending them our way to get those scopes done. The only problem is not even half of people get scopes done. I don't like going to the doctor myself either, so it's totally understandable. The colon and rectum, colon's about 4 feet long. So this is really kind of how it sits just in the human body, sitting just like this. Kind of starts on the right side, comes up across our body, comes down the rectum, and leaves from there. It's 4 feet in men and women alike. So when you get a colonoscopy, it's really just looking at the colon, looking at the rectum and the colon itself. Not really looking so much at the small intestine, because there's no great way for a scope to get all the way in there. That's 20-something feet. So 4 feet's easily seen with a colonoscopy. And that's where polyps almost always develop. It's very rare to have a polyp in the small intestine. So almost all cancer in the colon or rectum does develop from a polyp. Almost all, we're talking like 99.9%. So that's why we do a colonoscopy, because the most common patient that has a polyp has no symptoms. So if someone's 50 years old or so getting their first colonoscopy, the chance of them having a polyp is 1 in 3. 1 in 3 people will have a polyp. So we like to see them when they're real tiny, when they're like this, the one on the left side here, because we can burn that with a scope and it's gone, it's done. Left unchecked, then obviously it can sometimes grow to a large lesion here with a little ulcer in the center. This is probably a cancer just by looking at it. This was not one of my patients. This was just found off the World Wide Web, as it were. But just kind of an example to show you what can happen with time. Almost all polyps can be removed with the scope if found early enough. If they're too big to take out with the scope, that's when it requires a surgery to remove it. Because by definition, any polyp we can't get out with a scope needs to come out with surgery, because like I said, we don't want there to be a cancer within that polyp that we can't detect or that it would become one. So a couple myths about colorectal cancer and or rectal cancer. And just real quick too, you know, I know it's probably going to be the first question, or it usually is, why did you decide this field? I did general surgery for 5 years, and general surgery basically has some colorectal stuff, not a lot, but some other things as well, but it also has trauma, gunshot wounds, things in the middle of the night that are very non-conducive to family life. And God blessed me to marry my high school sweetheart. We have 3 kids, so I was away from them enough during residency. So this field allows me to still do big surgeries, some small surgeries, but call life is a little bit more agreeable. So that's the answer. I didn't grow up thinking I'm going to be a proctologist. It just kind of happened. You know what I mean? So some of the myths. Most patients with colorectal cancer get an ostomy or a quote bag. That's absolutely not true. That is the rare thing today to happen, especially with early detection, almost never. Now, there are some times if a cancer is located in a certain spot that they do require a temporary ostomy, a temporary bag for a few months, but that's a little more rare as well. As far as all patients require a quote major operation, I'd say 90% of the colon or rectal surgery that I do that's more major for a lesion, I do laparoscopically, either with small incisions here or sometimes use the robot. It just depends on the exact indications. So it's not a week-long hospital stay and all this stuff. It's 2-3 days in the hospital to do it typically. Just depends on the specifics of the exact lesion area. So as far as this is another little technique here that sometimes if a lesion, if it's a big polyp or a cancer, is located in just the right area, the patient does not even require a belly surgery. Like it's an outpatient surgery done kind of through the backside area while you're sleeping. Kind of like a colonoscopy, except a little more glorified. And that's a technique that's fairly new. That kind of, I got the expertise for that in colorectal fellowship, but that's just another example of saying it doesn't always require a big surgery, not even a belly surgery sometimes. Just depends on the specifics. And there's some details there that's not super important for you guys, but this is the operating scope that kind of goes in and does the stuff there. The video probably won't play, so I got some pictures of it. This is just an example of what I just talked about. Sometimes a polyp that's way too big, just way too large to take out with the scope, with the colonoscope. The colonoscope is about the size of your index finger. And the port inside that scope to remove polyps, you can imagine, is tiny, a little bit bigger than a pair of tweezers just at the end. So a polyp this big would never come out of there. So we have ways to sometimes, if it's low enough, if it can be reached, to take this out through the backside with that operative scope to prevent you from having to have a bigger surgery. Some pictures there, kind of there's the lesion once again. Then while the patient's asleep, I kind of can take it out, going through the wall there, kind of still continuing the resection all the way around, getting good margins on it. And then that very bottom picture is just it sewn up, and then that's the regular lumen above it. Those dissolvable sutures there. So that's the colon rectal kind of cancer side, polyp side. I'll save plenty of time at the end for questions. We'll go ahead and move to the kind of more benign disease of anorectal surgery. See several patients every single week with one of these problems, very common. Or a patient just comes in saying, I'm just having some rectal bleeding, some blood on the tissue or blood with the bowel movement, something like that. Can be painless bleeding without any symptoms except the blood, can be severe pain where they can't even sit down. So it just depends on exactly what the cause is there. So as far as hemorrhoids, everybody in this room has hemorrhoids. Every baby and their mama that's growing, every elderly patient has hemorrhoid tissue. If we did not have hemorrhoids, we would all be incontinent, every single one of us. Our muscle back there kind of takes about 3/4, about 75% of our control of maintaining continence and not having an accident is because of our muscle. The other 25% is because the hemorrhoids kind of fill that space up. So they are normal. The only problem is when they get abnormally dilated or prolapse or get a blood clot, then that's when they cause us problems, bleeding or itching or pain. More common in males, and that's theorized because of some of the more laborious things that males might do, or some of the more irresponsible things males might do versus females potentially. You can see the age 40 to 60 is the most common. The most common patient with hemorrhoids has abnormal bowel patterns, either constipation or diarrhea, but constipation is by far the most common situation. There might be some other things, but those are much more rare. So there's internal and external hemorrhoids. And that's just delineated by a fancy line here as far as the anatomy. Internal is just kind of, quote, on the inside. That doesn't really have many pain fibers to it. So that's the more common patient that comes in with painless bleeding. They're not really hurting, they're just having bleeding and they're concerned about it, understandably so. Internal hemorrhoids are the kind that sometimes you maybe heard people have rubber bands, place bands on them. That's an internal hemorrhoid, which we don't do that too often because that's sometimes not too definitive to take care of the issue. If someone needs a procedure, then they might need to go to the operating room to have that done. The good news is most hemorrhoids, I'd say 75%, require no surgery to take care of. Usually it's just medicine and dietary things that I talk about to patients when I see them in the office and all that kind of stuff. It's rare to have to do a surgery, okay, from my perspective. This is just a colonoscope here, kind of doing a scope procedure and kind of just turning the scope back on itself almost like a J, just seeing the hemorrhoids on the inside there. And these are hemorrhoids kind of that are coming out from the inside to outside, quote, prolapsing hemorrhoids. So the main way to treat hemorrhoids, internal, is just going to be medical. That's by far, like I said, most patients do fine with the medicine side, with fiber and certain medicines, like over-the-counter preparation H type of things, or prescription strength, just depends on how bad the issues are for them there. This is a sitz bath, just some warm water to help with some of the swelling. If they need surgery, there's different surgical procedures that can be done. Sometimes it requires a stapler, sometimes it requires, like I said, there's a rubber band procedure, or sometimes actually cutting something out. It just depends on the severity and how bad they're bothering the patient. But I try to not push patients towards surgery with hemorrhoids. Try to always treat them with medical, and most of the time it is successful. Because hemorrhoid surgery is very painful, as you can imagine here. These are external hemorrhoids. These are the ones that are very, very painful. Maybe you can't sit down, or it's very painful to have bowel movement, things like that. There's a wide spectrum from minor, moderate to very severe that does require surgery if it gets to this area. The reason the external are so painful is because they're right where all the nerve fibers are there. That's why they hurt so badly. And they can bleed if the blood clot swells enough, it can kind of irritate the skin that it causes some bleeding. Infection is very rare with hemorrhoids, internal and external. Almost never is infection present unless it's something else going on. So as far as the way to treat them, once again, almost always medical. Almost always medical. The surgery can be very painful, and that's just kind of a little diagram to try to point that out. So when I have a patient in my office, and I'm talking about hemorrhoid surgery, I'm going over it with them. You know, they've tried this stuff. I see them back in maybe 4 weeks or so, depending on the symptoms. If they fail that therapy and they just say, you know what, I just need surgery. I can't take it anymore. I'm tired of having to wear things back there. I'm tired of bleeding. I'm tired of pain, all that kind of stuff. I make sure they know that it is very, very painful. Very, very painful surgery. The first few days are just very bad. No matter, I give you pain medicine, we do certain things to get over it, it's still painful. But it's kind of like sometimes talking to my son, which he has his ears covered, and then later on he calls me and says he's hurting, and I say, I told you. So that's a similar deal. The most painful thing we see, period. If someone just came in the office and I haven't seen them, and on their sheet it just said severe pain, quote, passing razor blades kind of feeling, that's almost always going to be an anal fissure. An anal fissure is not a hemorrhoid. It is not a polyp. It is not a cancer. It is just a fancy way to say a tear that happens back in the kind of anal area back there. And I know this is super glamorous to talk about, so I appreciate y'all bearing with me. It's a good thing we're not having lunch. Sometimes over lunch you can imagine what this is like. But so an anal fissure, a tear. The most common patient that gets a tear is going to be from constipation. So all of us have had bowel movements that felt different than others, sometimes painful. Mild pain, we forget about it, don't think about it again, because the body, if a little tear happens, which actually it is this tiny, we're talking about about half a centimeter tear, but it can just wreak havoc on us because of where it's located. Because once this tear happens, almost always the body has kind of a self-protection mechanism in our squeeze muscles and kind of just has some spasm. Kind of knows something's happened back there, so it's kind of trying to help us out. The only problem is the blood supply to heal this tear comes right through that muscle. So the more that muscle spasms, cuts off the blood supply, it can't heal, then you have this terrible vicious cycle of bowel movement, walking, whatever, irritates that tear, it causes more spasm, and the patients are miserable. So, once again, the good news is, almost always can be treated without surgery. If they're seen and go, there's like 3 or 4 very specific things we kind of talk about in the office and get them to do with their diet and all, and usually surgery can be avoided. Once again, it's kind of a theme, fiber. Fiber's like answer 1, 2, 3. It's super, super important. I really just tell patients for everything we talked about thus far, 10 to 15 grams of fiber per day. And that can be in a dietary regimen by looking at the kind of labels there, or it can just be by supplements. Some people just don't want to eat certain things that have fiber in them, cereals or bars or whatever, or whole grain, whole wheat, then it's Metamucil or something like that. But I aim 10 to 15 grams minimum per day. So if that doesn't work, they come back and the fissure is still present, even though we give them some of this medicine that kind of causes that muscle to relax. And I'm a very specific compounded medicine. We usually get it from the compounded shop right across from our office there in Homewood on Independence Drive. If that doesn't work, then they have to have surgery to release some of that muscle. And as one of my mentors used to say, anytime you're doing surgery on your muscle, your squeeze muscle, you just can't trust that to anybody, because that's a very important part of your body. So as colorectal surgery, that's one of our areas of expertise. But like I said, most of the time it does not come to surgery. Most of the time it does not. So a fistula. So fistula's been around for, we're talking about like ancient times. And a fistula, it's not a hemorrhoid, it's not a fissure, it is a fistula. I know it sounds similar to a fissure. This is a patient who just has some kind of drainage from the backside area. Maybe they can say there's this little punctator, very small little opening that's outside their kind of opening back there that's beside it or so. And usually it just comes from a previous infection. And I have an infection next on there to talk about briefly, but basically, when someone gets an infection in the backside area, kind of right around the opening there, it's almost always nothing they did or didn't do. It's just going to happen. Just like a pimple on our face is not something we usually do or not do. Just like we have glands on our face that kind of keep things moist and all that kind of stuff, we have glands on the inside of us. And if one of those glands gets blocked, just like on our face, if a sweat gland gets blocked, that pressure has to go somewhere. So it builds up next to it, makes a pimple. The exact same thing happens in the backside area. A fistula results when that little tunnel, that connection between that blocked gland and that little abscess, when the abscess drains or it's drained by someone, if that tunnel stays open, that's called a fistula. It's just an abnormal connection between our inside area and kind of outside by the skin next to it. So usually it's not a dangerous thing, it just irritates patients because it's prone to get infected again. Sometimes leakage, sometimes can cause, patient might say, well, I'm incontinent. Well, they're not necessarily incontinent because their squeeze muscle is still fine. This is just a bypassing it. It's just going around it to cause some soilage every so often. There's a few different tracks here, and like I said, that's probably a little more for us to kind of concentrate on, just different ways it can kind of tunnel through back there. And that's kind of a perfect example of showing you, this is kind of the outside opening here. This is their normal kind of exit of their GI tract from their body, and you can see the connection from the inside to the outside there. And there's different ways to fix it. It depends on how severe it is and how it's associated with the muscle. Sometimes it's a temporary drain put in, sometimes it's just kind of cut open there. It just depends on the specifics of it. All right. So an abscess is almost always the cause of a fistula. So I do them in that order because I think it's more complicated if I do it the opposite way. There's some, I contemplated taking these pictures off here because they're a little bit kind of intense, but we'll kind of go through it pretty quick there. I'll probably just fly through it so you don't have to concentrate on it too much. But anyways, a perirectal abscess can be dangerous. Just like, we think about any abscess we have even on our arm, if it's left unchecked, it can be dangerous. If you saw a while ago, some of these, the reason a perirectal abscess or an abscess back in the area can be so dangerous is because all of these areas here are kind of interconnected. They're kind of, it's almost like a house with very, very thin sheetrock so that each compartment can easily be crossed by a severe infection. So what that can do is, unlike on our arm where there's just kind of two different compartments, but are separated by very thick fascia, strong kind of walls. In the backside area, it's very weak walls. So something that on the outside can look fairly minor, just a little bit of redness there, it can get very dangerous, can be life-threatening dangerous infection because it can spread in those areas that from the outside does not look too bad. And we see this probably, I'd say maybe a few times a year, somebody comes in with a life-threatening infection that started off as something very, very small back there, kind of like a bump. That's just some different forms of it there. Like I said, that's some of the details. There's a lot of different reasons for it. Most commonly from an obstructed gland, like we talked about. Sometimes it could be from trauma, could be from other issues. Sometimes a cancer can hide within an infection, can kind of mimic one, if you will. Crohn's disease, different things like that. So this is what I was talking about here. This is kind of a blown up view, kind of just looking at the front if we cut ourselves in half and then take the front part off. And you'll see these different compartments here. It can easily cross into these other areas, even cross into the lower belly cavity. That's why it can be such a dangerous situation if left unchecked there. Most patients, unfortunately, come in and see you right off the bat, obviously. If you're hurting bad back there and something's abnormal, patients usually come in, so that's a good thing. This is severe infection. So like I said, I don't want to gross anybody out. I'm not trying to do that, honestly. Just saying how on the outside it doesn't look too terrible. This is the kind of infection that spread from the backside forward, and then you can see the very extensive debridement that was required to take care of that. So it can be very serious. Be very, very serious. Can require a bag to be placed for those patients. The final thing here is pruritus ani. Fancy way just to say itchiness in the backside area. This is one of the most common things we see. I'd say at least 2 patients a day probably come in with this exact complaint. The most common cause of it is, it's a lot more common in ladies than men, because I think ladies are probably more clean than us men, because it's usually kind of a aggressive hygiene thing. And like I said, I guess men just are not that clean. I don't know, but ladies are the ones that usually come in with it. But it's kind of just a kind of an over-cleaning kind of thing, you know, and that's just really the thing. It has nothing to do with cancer, has nothing to do with polyps, has nothing to do with hemorrhoids, has nothing to do with fissure. Anything else we're talking about is kind of an issue in and of itself. And it's really just a fancy way to say kind of an abrasion of the area back there, sometimes with over-cleaning, with being too aggressive about it. It does require an exam just so I can make sure there's not something else going on that could be causing it. Assuming everything else is fine, then most patients by far do better with only conservative measures as far as just being very gentle. Kind of almost a hands-off technique, keeping things dry back there, not kind of putting any kind of scented wipes or anything on there that could have the chemicals that can irritate things. But most patients get better with that. Sometimes it can be due to like an allergy, especially any kind of drink or food that has kind of oils from the husk or from the bean, such as caffeine, you know, like some of the good things in life. Caffeine, chocolate, some of the yeast of alcohol, and some tomato-based products sometimes can cause it, but most patients get better just with the hygiene talk, and that's about it. Very, very rare to have to do anything about it. Almost, there's really no great procedure to do for it, so surgery is almost never needed. And that's it. Hope I didn't talk too fast, and you know, but that's the main thing. So we can questions about any of it.